Welcome to Mastering Section GG, Functional Abilities, on the MDS Assessment. In this video, we'll help you identify the various components of Section GG. Understand the coding instructions. Accurately complete each item. Prevent common coding errors and misconceptions. And recognize the impact of Section GG on identifying the resident's needs and developing a plan of care. One of the more comprehensive and considerably more complex sections of the MDS provides a space to assess the various domains of a resident's functional abilities. It includes items specific to prior function, admission and discharge performance, performance throughout the resident's stay, mobility device use, and range of motion. Here we will begin with reviewing prior levels, a section exclusive to admission, and 5-day PPS assessments. Our section begins with items GG0100 and GG0110 for prior functioning and prior device use. For these items, we'll be referring to the resident's usual performance before this current spell of illness. Here we will indicate the resident's usual ability with everyday activities such as self-care, indoor mobility, stairs, and functional cognition. To assess, we can ask the resident, their family, or review the resident's medical record for documented references to these items. The following item set will be GG0115, Functional Limitation in Range of Motion. This item allows us to determine whether any functional limitation in range of motion interferes with the resident's activities of daily living or places them at risk of injury. To assess, we'll begin with reviewing the medical record and by talking with the resident, staff, or family about any impairments in functional range of motion during the 7-day observation period. Coding for this item will include a 3-step process, beginning with testing the resident's upper and lower extremity range of motion bilaterally at all joints unless contraindicated. If limitations are noted, the next step will be to determine if the limitation interferes with any activities of daily living or places the resident at risk for injury. If it does, proceed to code this by identifying the laterality and locations of the impairment. It is important to understand that when coding, your assessment is not based on whether or not the resident has any limited range of motion, but rather, if the limited range of motion has an impact on any functional abilities or places the resident at risk for injury. For our next item, GG0120, we will record all of the different mobility devices the resident normally uses for locomotion within their room and in the facility, such as canes, crutches, walkers, wheelchairs, or limb prosthesis. Review the medical record for references to locomotion, talk with staff or family members, and utilize direct staff observation during the 7-day observation period to select all that apply. Shifting gears, we'll now dive into the last, but largest component of Section GG, often referred to as the Functional Abilities and Mobility Assessment. This assessment utilizes a widely recognized 6-point scale to gauge a resident's usual performance in a range of daily tasks. These tasks are divided into 2 main categories: GG0130, self-care, and GG0170, mobility. Before we begin, let's review some basic definitions and guidelines that will be referenced frequently in the preceding items. The Functional Abilities Assessment is a way to measure how well a resident can do everyday activities, and the 6-point scale measures how much help they need to do them, from doing it completely on their own to needing total assistance from a helper. A helper must be a facility staff member directly employed or contracted by the facility, for example, agency nurses. It does not include individuals hired outside of facility management, such as hospice workers, students, or family. Usual performance will be used when the resident's functional abilities fluctuate. Do not code based on their best or worst performance, rather, code based on their usual ability. Now, in order to capture the most accurate picture of the resident's ability, we'll be collecting data from a variety of sources over a 3-day period. Depending on the type of assessment, we'll determine which 3 days within our look-back we will use. The 3-day data collection period will be based on the specific MDS assessment type. For an admission and/or 5-day PPS, Day 1 will start on the date of entry, followed by the 2 consecutive calendar days. For a quarterly, annual, or IPA, we'll be using the last 3 days of the look-back period, with the ARD serving as Day 3. This will also apply for discharge assessments and end of PPS assessments. While this process might vary from facility to facility, CMS anticipates that an interdisciplinary team of clinicians is involved in assessing the resident during the assessment period. This means that members of the IDT will be responsible for reviewing the data gathered within the observation period and utilizing clinical judgment to collaborate and determine the resident's usual performance that will be used in this section. Before assessing the resident's functional abilities, it's important to familiarize yourself, staff, and any other disciplines that will be involved in the documentation process on the 19 different self-care and mobility activities that are included in this section, in addition to the 6-point level of assistance scale and the 4 activity not completed options. The steps to assessing each activity will begin by allowing the resident to complete every activity as independently as possible, as long as they are safe, regardless of how the resident performed the activity prior to the current illness, exacerbation, or injury. Activities may be completed with or without assistive devices or equipment, unless the assistive device or equipment is only available during therapy or while working with rehab, for example parallel bars. If helper assistance is required because the resident's performance is unsafe or of poor quality, score according to the type and amount of assistance provided. This will be accomplished by utilizing the 6-point scale, a method used to gauge a resident's capabilities by measuring the amount of assistance they require from a helper. The scale, ranging from 1 to 6, provides 6 unique levels, each representing a distinct ratio between the resident's participation to the amount of assistance that was required to complete the task. Starting with 6, independent, meaning the resident completed the entire activity before, during, and after, on their own, with no assistance from a helper. 5, setup or cleanup assistance, will be an appropriate choice when the only assistance provided was strictly limited to setting up beforehand or cleaning up after, nothing during. 4, supervision or touching assistance, should be used if the helper performed any of the following at any point during the activity: watched or observed the resident perform the task, provided verbal cues, coaxing or prompting, or extended a form of touching assistance such as steadying or contact guard assistance. 3, partial or moderate assistance will be used if the resident completed more than half of the activity on their own and the helper provided less than half of the effort. Opposite of that, 2, substantial or maximal assistance will be used if the resident completed less than half of the activity and the helper provided more than half of the effort. Lastly, 1, dependent, should be used if either of the following applies: the helper does all of the effort or the assistance of 2 or more helpers was required. In this part of our video, we'll now cover the 4 alternative options that are available when the activity was not completed. These will include resident refused, not applicable, not attempted due to environmental limitations, and not attempted due to medical condition or safety concerns. Beginning with 7, resident refused, should be selected for every time a resident refuses to complete the activity. Next, Code 9, not applicable, will only be used if both of the following criteria are met: the activity was not attempted and the resident did not perform this activity prior to the current illness, exacerbation, or injury. Following will be 10, for not attempted due to environmental limitations. This is an appropriate choice if the resident did not attempt this activity due to environmental limitations. For example, a lack of equipment available or weather constraints. And lastly, 88, not attempted due to a medical condition or safety concerns. Use this if the activity was not attempted due to a medical condition or any other safety concerns. Lastly, we'll conclude our video with a brief overview of the activities that make up our functional abilities and mobility item sets. GG0130 Self-Care provides a list of common activities related to daily living. In this section, we'll be applying our coding knowledge to determine the resident's usual performance in the following tasks. Eating measures the ability to use utensils, when applicable, to bring food or liquid to the mouth and swallow. If the resident is NPO, code 88. Oral hygiene measures the ability to clean teeth, dentures, or gums if the resident is edentulous. Toileting hygiene will be the entire process of managing clothing and cleaning the perineal area before and after voiding or having a bowel movement. This applies when using a toilet, commode, urinal, bedpan, or on a toileting program. If a catheter or ostomy is used, code based on the ability to clean around the area, not device management. Shower or bathing includes the ability to wash, rinse, and dry one's body from face to feet in a shower, tub, bed bath, or at a sink. It does not include washing the back or hair. Upper body dressing, lower body dressing, and putting on or taking off footwear will gauge the resident's ability to dress upper body, lower body, and footwear. If the removal of elastic bandages, orthosis, or prosthesis are required when changing, Include this in the assessment as if they are a part of the resident's clothing. Of note, this item cannot be assessed based solely on donning or doffing a hospital gown. Lastly, when present, personal hygiene will measure the resident's ability to perform personal hygiene tasks such as face or hand washing. Our final item set, GG0170 Mobility, provides a list of common activities related to mobility and locomotion. In this section, we'll be applying our coding knowledge to determine the resident's usual performance in the following tasks. Roll left and right measures how much help the resident needs to roll side to side in bed. Resident can use bed rails, side grab bars, or trapeze, and should include rolling onto both sides, left and right. If the resident sleeps in a recliner, code 88. Sit to lying will gauge how much help the resident needs to move from sitting on the bed to lying down. This includes the act of lifting legs, repositioning body, and lowering head onto pillow. Lying to sitting on side of bed measures how much help the resident needs to move from lying flat to sitting up at the bedside, including trunk lift, leg swing, and the ability to balance at the edge of the bed. Sit to stand measures moving from sitting to standing, from any surface. Chair to chair transfer measures transfers between bed, chair, or wheelchair and includes stand pivots, squat pivots, or slide board moves. Toilet transfer is the act of simply getting on or off toilet or commode, and does not include wiping or clothing management. Car transfer measures the ability to get in and out of any safe or simulated vehicle. Curb, 4 steps and 12 steps will be the resident's ability to safely go up and down steps or a curb, including a single step or curb, for steps or 12 steps, using rails or devices as needed. Picking up object gauges the resident's ability to bend or reach from standing to pick up an object from floor. Walking 10, 50, or 150 feet, with or without turns, measures the ability to walk various distances and complete a 90-degree turn. Each distance may be attempted at different sessions. If rest breaks are required before the resident reaches the desired length, consider coding 88. Will 50 feet with 2 turns measures the ability to self-propel a wheelchair by using hands or feet to move the chair. Now before we end, here are a few quick coding tips and common mistakes to avoid, directly from the RAI. Usual performance. Always record the resident's usual ability, not their best or worst. Usual means how they typically perform across different times and situations within the 3-day assessment period. The term helper only includes facility employed or contracted staff. It does not include hospice, student nurses, or family or caregivers. Admission and baseline assessment. Conduct the admission functional assessment before treatment begins whenever possible. This shows the true baseline prior to therapy benefits. However, treatment should not be delayed if clinically necessary. Dependent also includes situations where 2 or more helpers was required, even if the extra helper provides minimal or standby assistance. Devices used. Include any assistive devices available in the facility setting, but exclude any devices that are restricted to therapy only, such as parallel bars or harness systems. Section GG plays a pivotal role in understanding some of the resident's most basic needs, which is why coding accuracy is imperative. For more information about coding the MDS, or to see more MDS-related content, follow our channel at MDS Made Easy. Brought to you by the Data Nurse, your partners in MDS Precision.